And welcome to Deuk Spine. I'm Dr. Deuk Majin, and we are performing a cervical Deuk laser disc repair. AP. Our patient has two herniated discs. One really bad, C4-5. The other one not quite as bad, lateral, C3-4. But he's got other herniated discs as well. These are the two worst ones. The 4-5 is really bad. 2, 3, 4, 5. Shot. Shot, AP. We're approaching the C4-5 disc from the front. That looks really good. Lateral. We're dead center. I'm going to enter the disc from the front with this needle. We're going to do a discogram shot. And then we're going to see with the discogram dye the tear in the back of the disc and the herniation. He's got a massive herniation shot. There it is. Look at that herniation. It is big. We're going to be making our incision. Now this surgery is being done instead of a fusion. Other surgeons would offer fusion. I've offered fusion. We talked about fusion. He didn't want fusion. I don't blame him. Jordan, we got a rotational issue. Maybe Burndes can fix the rotational issue. Yeah, just a little bit, thanks. Incision. Let go. I've just made a 4mm incision in the front of his neck. Shot. Thank you. Shot. All right. Yeah, I've still got an off on orbit by 2 degrees. Shot. Maybe the other way. Shot. I'm leaving the guide wire, removing the needle. Thank you. Going to bring the dilator down. We've probably got a nick on the external small vein. All right, heading down. Shot. Perfect. I think you fixed the orbit, but not completely. Let's do another degree. Can you guys see which disc we're going to? Number 2, 3, 4, 5. Everyone agree? 4, 5. Shot. Thank you, Luis. Almost there. Yep. And again, I'm using the guide wire to guide the dilator. Henry, let's show the audience, why do these herniations cause pain? We're not doing this surgery so much for pain. We're doing this to decompress the spinal cord and nerve roots. AP? Shot. Welcome back. You can see from our video that the problem that causes neck pain is actually related to the disc. The disc has nerve fibers in the back. These nerve fibers are pain fibers. Normally they're not active. They don't cause pain, but when a patient has a tear in the back of the disc, that tear will get the stuffing from the center of the disc stuck in it as the stuffing is leaving, trying to get out. We call it a herniation. That tear and herniation then cause horrible neck pain. That neck pain is what causes pain in the neck, headaches, arm symptoms. It's all due to inflammation. I'm starting at his worst disc, number 4-5. Really hope this works for him. No, that's not the right thing. Here, let me help you. Any questions?
At this moment, no current questions.
All right, Henry, let's show the audience how the Deuk laser disc repair works.
Copy that.
and we'll come back. At this point, we're removing pieces of herniation from the back of the C4-5 disc. Every one of these is a herniation. The inner diameter of the tube is 2.8 millimeters, so you can imagine, based on the size of these herniations, that how big they are. All right. The blue is the laser. That's a plastic covering around it. Now, some people with neck pain end up having facet joint pain, right, Henry?
Yes, sir.
And when you have facet joint pain, well, operating on the disc isn't going to help. So you need to operate on the actual facet joint. And do you have a video we can show the audience on facet joint pain?
Of course.
Facet joint injury is a common cause of chronic neck pain. The inflamed facet capsule tear generates pain signals. The best treatment for facet joint pain is the Deuk plasma rhizotomy. The inflamed facet joint pain nerves are destroyed. The advantages with the Deuk plasma rhizotomy is that it's an outpatient procedure that takes 30 minutes to complete, very minimal bleeding and pain after the surgery with immediate recovery and return to work the next day, as well as a 99% success rate and permanent pain relief with a single treatment. For more details, please visit our website at www.deukspine.com or call us at 1-800-FIX-MY-NECK 349-6963.
All right. So you've been watching our video on facet pain. Again, that's not a problem this patient has, but we like to teach while we're doing surgeries, and I think it's important that people are aware of different causes of pain. In this case, this patient has a lot of disc herniation. We've been taking a bunch of pieces out with the grabber, and while you guys are watching that video, and unfortunately they're pushing on his spinal cord. There's another piece. He kind of blew this disc out pretty bad. I'm hoping I can get all the pieces out. And I was a little worried about this one because it's so much herniation. What I mean by that is, it's not that it's so much herniation I can't get all the pieces out. What I mean is, it's so much herniation, is the disc going to be able to heal properly? Or is it going to be incompetent and re-injure again? We talked about this before. There's another piece of herniation right there. There's just so many. So will this disc reseal with all this damage? That's the real question. Nobody knows the answer to that, but I think it will. I can't prove that it will. Time will tell. But he really did not want a fusion. We talked about it, and I don't blame him. I wouldn't want a fusion either. I told him if this was my neck, I would do this surgery here and, you know, just really take care of my neck. And that's a big piece. Got another big piece out. Taken about 10 big pieces out so far. I think there's more. Still more. There's another one. Now you can see these are called fragments. Fragments of disc herniation. Another one. And honestly, I just put this tube back there at the back of the disc where the herniations are, and they're kind of just floating out so far. None of them are really scarred down. Yeah, don't mess with that when I'm doing this. Don't mess with that when I'm doing this. It changes the tip of the scope, so it shifts it, right? You understand? Yeah, and then it doesn't go where I want it to go. I don't think I got it. I can sort of see it. There, we got a piece. Again, a herniated disc is not one piece of herniation, it's a lot. In his case, a lot. These are all pieces of herniation, new ones. See it? I just cut a piece. It was a bigger piece. I cut it in half, and now I'm floating out one piece, and I'll float out the other. But they really don't have anywhere to go except up the tube, right? They're stuck in the back of the disc, and they're pushing on his spinal cord, pushing on his nerves, and I'm giving them a place to go, a way out, basically. They're under pressure because there's so many of them just crushing. That's a big piece. I'm going to have to take that out with the grabber. I don't think I got it. Don't let that blue wire hang down low. This piece is a bit more dense. It's got more calcium on it. Doesn't want to float out. Here we go. How's our pressure on our irrigation? Fucking waste of time. That should have gotten it. All right. Progress is slow but steady. There's the spinal cord down there. That's right here is not the spinal cord, but You could see it just at the 12 o'clock right there. Any questions?
At this moment, no current questions.
All right. We've taken out about 15 pieces of herniation so far. What's the issue, guys? Oh. Do we not have enough pulse oxes? Can buy more if we need them. They're not that expensive. All right, what I was saying is that's the spinal cord right there. You guys see that white area?
Yes, we do.
That's where all the herniation was. It was pushing on it. I want to clean it up just a little bit more here. I just want to make sure this heals really as good as we can make it. You guys see the spinal cord, right? Right there, that white thing?
Yes, we do.
Still a little bit of herniation around it. I'm going to try to remove some of it.
We have a question.
Uh-huh.
This comes from Micah on Facebook,
Hello, Mike on Facebook. Welcome.
asking, is the size
flip
of
it.
this herniation common?
No. This is a bit bigger than normal, Micah. Normally they're smaller than this. I'd put this up in the 90th percentile for size. This is a lot more herniation than we normally would see. I don't know if Henry showed you guys a good picture of the herniation before surgery on the MRI, but it's pretty bad.
I showed it earlier. I can re-show it again.
Mm-hmm.
Also, we have a comment coming from Dale on Facebook
Dale, welcome to
Sa-
our stream.
saying, good day from Australia.
Nice. Good day. Thank you, Dale. I thought you were going to say that's not a knife. This is a knife.
This is a knife.
Oh, Crocodile Dundee.
Great movie.
Well, what time is it in Australia? Is it morning?
I think it is. Let me check.
Are they? I think they're ahead of us, right?
Yeah, I think
Australia?
they're 12, maybe 14 hours ahead.
Huh. Well, Dale, thanks for joining us. We are in the foramen on the left side at C4-5, and I'm removing herniations. It's another loose fragment right there. You can see these herniations are loose, meaning they just kind of floating around. Once we open things up, we give them a way to get out. But they're not always that way. Some of them are scarred down. And this one in particular right here is scarred down. See the scar tissue, the white stuff? I apologize for the poor visibility, but these over here are scarred. This stuff is scar tissue. Now we're not here to get rid of scar tissue. If we were, we'd be here all day, and quite frankly, it just grows back. But we're here to get rid of the herniations. It's actually the herniations that cause the scar tissue. Get rid of the herniation, we get rid of the source of the scar tissue. Okay, that side looks good. I'm going to come back and look towards me. We're almost done here. And we got another herniation to go take care of at 3-4. There's the spinal cord right there. You see it? The dura.
Yes, we do.
And that's a good sign. That's what we want to see. That means we've cleared out all the herniation there. Here's a piece. Still got to get that guy. So I'm moving over to the other side right now. Gosh, these things just don't want to float out. These are herniations, by the way. This is what they look like under the scope. There we go, finally. Come on. Those are the end plates you're seeing, left and right. That's the C5 superior end plate posteriorly at the back end. End plate is bone. That's the vertebral body, basically. The back of the vertebral body called the end, top and back called the end plate. This stuff here is herniation. Just using my laser to remove it. Now, what's the advantage of this surgery that we're doing over ACDF, more traditional, older type surgeries? Number one, no bleeding with this surgery. No bleeding. Number two, no hospital. We don't go to the hospital. Patients go home right after surgery. Number three, what do we got here? That's interesting. I got to figure that out. Not sure. That may be a piece of herniation there. Big piece of herniation. Number three, we're not putting metal in his neck. All right? We don't use metal. We don't do fusion. It's all natural. We're basically cleaning up the herniation and tear, letting his body do the rest to heal it. Okay? So he's not going to get metal. And hopefully this surgery will fix everything so he doesn't need metal. I think that's a herniation there. It's not all herniation, but some of it. We're basically looking from one side of the disc to the other. This is number 4-5. This is the really bad one. These are more pieces of herniation. I've taken out about 30 pieces so far. And there's still more. I'm trying to get as many as I can. One thing I tell everybody is I can't get all your herniation. Nobody can. No doctor can get 100%. There's no such thing. And the reason is simple. There's no surgery that allows us to get 100%. You're not going to get 100%. It's just not humanly possible. So my goal is at least 50%. I want at least 50%. I know if I can get 50% of that herniation out, that my patient's going to feel good. They're not going to have symptoms. Now, of course, I try to get 100, but I already know I'm not going to get 100. So I'm not delusional. And I always talk about don't gild the lily, meaning don't, go for an unrealistic result that you can't achieve. And that's going to end up hurting the patient while you try. So, all right, I don't see much else. I'm just going to keep removing this herniation over here, cleaning up this tear. You guys can see the fibers, right? The annular fibers there
Yes, we can.
from the tear. Bone spur. I'm going to keep trying to clean up these fibers just a little more. Keep getting little pieces of herniation popping up at me. Any questions?
No current questions, but we do have a comment from Dale on Facebook saying that it is currently 7:09 in Australia right now.
AM, I guess, right?
AM, correct.
Awesome. I love it. Wake up in the morning, have your OJ, hug your wallaby, and put on the Deuk Spine live surgery channel. That's pretty cool. I was just talking, who was I talking to about Australia today? Visiting. Oh, Richard. He lived in Australia for years and just thinks the world of that place. I would love to go see Australia someday. I've got family over there. I think they're in Melbourne. I guess Melbourne is the southernmost city. Have you ever been to Australia, Dr. Berndes?
No, never once.
All right, we're almost done here. I got 1 minute left on this disc. Anybody here been to Australia? Dale, where are you at in Australia?
That is a great question. I will answer that once he replies.
All right, I'm messing around in the foramen here. I can't tell what I'm seeing. It sort of looks to me like it could be scar tissue versus herniation. If it's scar tissue, I kind of want to leave it alone, but it looks like there's a little bit of herniation in there. Yep, sure is. Look at that. And that's really, that's it. Look at that. Came out. That's as probably as clean as I can get this. Take one more peek.
Dale just commented, and it was the answer I was hoping he would say, is he said, I'm in a country town called Ehuka, which is 2 hours out from Melbourne.
Awesome. We're done with this disc. Well, welcome. I hope to come to your beautiful country someday. I've often thought in another life I probably would really like living in Australia. But God put me here, and I don't question God's intents. I just do what I'm supposed to do. Feel the same way about my wife. I just do what she tells me to do. Then I don't have to deal with all the nagging and guilt afterwards, right, Berndes? Dilator. All right, we're done with one. We're going to move on to the next. The next one should be a bit easier to do, but I feel good about this one. Feel like we got all the herniation that we can out, and I didn't see any more left there. So, all right. Shot. 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 All right, at this point, that's 2, 3, 4, 5. Everyone agree we're at 4, 5? We need to do 3, 4. Everyone agree we need to do 3, 4? All right, so let's move up. Shot. This is called the Deuk spine slide, and I pioneered this technique. It's never been done before. When I learned to do anterior cervical transdiscal endoscopic surgery from the Koreans and Dr. Reuten in Germany, they had never done more than one disc. They had only done one disc shot, and they would just do one disc. But the problem is a lot of patients, lateral, they end up having more than one disc that needs surgery. So what are you going to do? Bring them back 3 times if they have 3 discs? The average number of discs per patient is 2.4. Shot. So if you think about that, each patient has 2.4 discs that need to be fixed. Shot. Let's get an AP. And that means you got to bring them back 2.4 times on average to fix their neck. Well, why would anybody want to go under anesthesia 2.4 times or 3 times? I wouldn't. I just want my doctor to fix it all. Wait, stay there. In one shot. Shot. Perfect. Lateral. All right, we're in the middle. We're over 3, 4. I've just got to check my lateral view to make sure I haven't moved. And I'm still over the disc, which we are. And now I'm going to advance the dilator through the disc. People ask me, don't you damage Don't you damage the... Let's get an AP again, just to make sure we haven't moved. Let me just see where we are before you do anything. I just want to make sure we're not moving. Left or right. Perfect. We're in the middle. Lateral. He's got some arthritis in his facet joints. I don't know if you guys can see that. Jordan, show them on that view. Henry, keep it on the x-ray view.
Copy that.
See the arthritis there? And look at the bone spur there to laterally. Yeah. And the one up there. Yep, that big bone spur. Those are all bone spurs. So I'm surprised he doesn't have facet pain, but he doesn't. He just has this disc problem. Hopefully he never develops facet pain. We never know who's going to have facet pain. Shot? Shot? I mean, we can diagnose shot facet pain. Thank you. If they have it, but if they don't have it, we can't predict who's going to get it. Shot? Shot? That's it? Nothing coming out. That means he's got a lot of scar tissue here. Nothing? All right. Well, I couldn't get any dye out because the disc is too scarred up from inflammation. Wow, man, that's incredible. Any questions?
No current questions, but we do have a comment coming from Michael on YouTube saying, please come and bring the laser and the team. I can't wait to get the DLDR. Let's go, Dale.
Ha! Is Michael in Australia too?
That's a great question.
Sounds like Michael may be in Australia. Yeah, you're right. Australia needs this. The rest of the world needs it. Unfortunately, the companies that shot, oh, look at that thing move out. Got to put it back. Wow, this disc is under a lot of pressure. So there's a lot of inflammation in 3-4. Try to get the orbit right. Man, that thing keeps coming back. It's like under so much pressure, it's just pushing the dilator backwards and pushing my tube backwards. It's crazy. I've seen inflammation pressure shot before, but this is insane. Shot. Shot. I mean, as I'm hitting it, I'm feeling it bounce back. You give me some more orbit. Your orbit's off. Gosh, the tube's going backwards. I've never seen that. I've seen the dilator go backward. I've never seen the actual tube go backward. Holy smokes. All right, that's as good as we're going to get this. All right. Appreciate all your support, being here. That's my team and our viewers. Irrigation is very weak. Why? Get that fixed. You guys got to be paying attention to that irrigation. Something wrong. Is there a kink somewhere up here, guys? What is this shit tubing we're using? Is this like the new, we'll charge you twice as much, but we'll send you shitty tubing? It may look the same, but it's not performing the same. Therefore, it cannot be the same. Right? That looks like an apple core, yeah. That piece of herniation, it sure does. I'm gonna grab that out. I don't think I'm gonna get it. It's all scar tissue from inflammation from the herniation. It's really thick. I'm just gonna have to laser it. All right. Look at that, calcium. Nasty. Any other questions, Henry?
No current questions, but we do have a comment coming from Michael once more on YouTube. When we asked if he was from Australia, he says, "Yes, I am. I did my MRI review earlier this year, and been working hard to get over there."
Okay, great. Wonderful to hear, Michael. Thanks for joining us. Sounds like we got a pretty good group from Australia here. We get a lot of Australian people finding us. One of my neurosurgery instructors was Australian at the University of Florida in Gainesville. One of the best neurosurgeons I've ever worked with, Dr. Stephen Lewis. He was from Perth, and he was a cerebrovascular neurosurgeon, meaning we got 5 minutes, Dr. B, 5 minutes. Meaning that he did aneurysms, AVMs, skull-based tumors. Rotate, let's go. Phenomenal surgeon and a good teacher and just a good guy, very down to earth. I enjoyed working with Dr. Lewis. Not sure how he ended up at the University of Florida in Gainesville where I trained, but he was there. Actually, I think I know how he ended up there. He replaced Dr. Arthur Day. Art Day was our preeminent neurosurgeon, cerebrovascular surgeon, and Art Day left, went to Harvard, became the chairman at Harvard, and Dr. Lewis took his place. Come on. Let's see shit, Louis. This is incredibly scarred up here. It's just a giant ball of scar tissue from years of disc inflammation. So what we call this is debulking. Debulking means you're removing some of the bulk. Thank you. That's really a herniation does a lot of its damage by pressure on surrounding structures. Spinal cord, nerve roots. And by getting some of the mass from the herniation out of there with the laser or grabbers, surgical tools, you can reduce the amount of pressure effect it has on the nerves, spinal cord, and that's really what we're doing here. That's all we can do. Why can't I get more lateral? I think we're done, Dr. B. Hopefully you're ready to wake this patient up. Let's flip it. For this disc, you notice the difference, right, from the last one? The last one had lots of pieces that came out. This one just had scar tissue. Most of the herniation is just not really there. It's more scar tissue. And we got a lot of it out. That should help the patient. Any questions?
Yes, we have 2 questions. This first one coming from Dale on Facebook.
Hi, Dale.
Asking, what is the rough price of this procedure, and is there an insurance that covers that cost?
Yeah, I don't know about Australian insurances covering the cost. I don't have the cost of the procedure. We have people with that information, and we always tell patients ahead of time before they come out here what they're going to have to pay for what we're treating. So you'll know exactly what you pay. But yeah, you need to do an MRI review. We need to figure out what needs to be treated, and then we need to, one of the schedulers will look at insurance, and if you're coming from Australia, chances are you don't have insurance that covers it. So they will give you a self-pay price, basically a cash price, which is, a good price. And yeah, but I don't have that information. Those are the surgery center schedulers. All right, guys, you see the incision is 4 millimeters. It's tiny, tiny little incision.
Yes, we do.
And I'm going to put a steri strip, and then I need a 4x4 right after. Okay.
We do have one more question.
Sure.
Coming from Michael once more on YouTube, asking, do I need to book another MRI review prior to coming? Would be great to go over everything again, and I totally understand if it will be out of pocket.
Michael, I honestly don't know. I don't remember when we did your MRI review, but if you've had your MRI review done within the last 3 months, then I would say you're probably okay to just proceed. If, maybe even 6 months, unless you've had a significant change in your symptoms. If you've gotten a lot worse, then we should get a new MRI and do a new MRI review. But other than that, if your symptoms are just waxing and waning and, typical, then 6 months ago or earlier would be fine. All right, blood loss is 0.5 mil, which is 10 drops. Scope use is 7. Any other questions?
No current questions.
All right, great job, everybody. Henry, you're welcome to end our stream. We have one more surgery to go.
Not a problem.